Well, thanks to the panel. Good morning, everybody. I'm pleased today to share with you one of our complex cases that finally didn't go well, actually, because we chose a wrong two-stent strategy. So I have no conflicts of interest. Our patient is a 35-year-old male. He is non-hypertensive and chronic heavy smoker. He presented to our center by non-ST segment elevation myocardial infarction. His electrocardiogram showed ST segment depression in the infralateral leads, and his echocardiography showed wall motion abnormalities in the territory of LCX and the RCA. His right coronary angiogram showed mid-segment total occlusion. It was clear that the proximal cap is tapered with a very short segment of CTO. Probably his JCTO and progress CTO scores would definitely be low, with a high success rate of crossing in the first 30 minutes. He also had well-developed retrograde collaterals from the LAD. His left coronary angiogram showed significant disease, subtotal occlusion in the OM, first OM, significant disease in the distal LCX and the proximal first diagonal. The LAD distally showed diffuse disease. So we calculated the syntax score was 20, and we went for heart team discussion, which finally favored to go for a PCI. So adopting the hybrid approach, we went with dual injection with a right Jotkin catheter engaging the RCA, and with the aid of the microcatheter and dual injection, we were finally able to cross the lesion within 15 minutes, and the Gaia second was parked distally. That was finally exchanged over the microcatheter with a BMW wire, and we finally stented the RCA using two overlapping stents, followed by post-dilation with an NC high-pressure balloon. Now back to the difficult situation here on the left on the left system. It was quite clear that the origin of the first OM branch had a difficult takeoff. It will definitely be difficult to wire. So finally, we were able to cross the lesion using a polymer-jected wire Pilot 50 with the aid of a small compliant balloon. After crossing the lesion, we performed pre-dilation using a small compliant balloon 2 × 20 in both the LCX and the first OM branch. It was clear that during balloon dilatation, the angle between the OM and the LCX was almost acute angle, almost 70 degrees. And it definitely had an impact on our decision which strategy to choose. So after balloon dilatation, we had dissection flap in the proximal segment of the OM, and we have some minor flaps dissections in the LCX as well. At this stage, we had several options to choose, either to go provisionally treating the LCX proper as a side branch and go for a stent from the ostium of LCX into the OM, or to choose a two-stent strategy from the start. And according to the angle here, which you have seen during balloon inflation, we chose to go through for DK crush technique. So we started with stenting of the side branch here, the OM, using a 3031 millimeter drug-eluting stent with a non-compliant balloon in front of the ostium of the side branch, ready to crush the stent after its deployment. Then we removed the wire and crushed the stent using the 3.5 20 millimeter balloon. After this step, we have to rewire the side branch through a proximal strut. However, we failed using different wires to cross this area. So probably this crushing didn't go smooth. So we had to change our strategies. We thought that if we stepped back to the classical mini crush technique, we might be able to change the bifurcation area, and we finally might be able to recross the side branch. We did this, and it was surprisingly easy to pass a 3046 millimeter stent into the LCX, and we performed post-dilation to the LCX stent with high-pressure balloon, and then we drew back the wire, and we were finally able to recross the side branch stent. We performed post-dilation for the side branch stent, and now the next step was to reintroduce the wire into the main vessel. But actually, we again failed to cross the lesion at the area of the bifurcation, and the only wire that was easily passed through this area was the Gaia second. And after passage of the Gaia second, we were finally unable to cross the bifurcation area even by a very small balloon. So we aborted the procedure at this stage, and this was the final result on two different views. And it's clear here after stenting that probably this angle is not acute, as that we have seen while we pre-dilated both vessels. So we stepped back trying to understand what happened here. This is what happens when you go for a DK crush for an angle less than 70. You definitely will be able to crush few struts that are protruding into the main vessel, and after balloon dilatation at this area you are crushing the proximal part of the struts away from the carina to one wall on the other side. But if you are having an angle more than 70 degrees approaching 90, you are actually crushing the struts in front of the ostium of the side branch, so it will be extremely difficult to recross the side branch if you have this done. Even if you are able to cross and you post-dilated, you will probably crush more struts into the main vessel, and that's why we were not able to cross the balloon into the main vessel. So my take-home message today is that the bifurcation angle is dynamic during PCI. You have to carefully assess the bifurcation angle at every step prior to choice of the technique, and definitely if the angle deemed to be more than 70, it wouldn't be appropriate to choose the DK crush technique. And please keep in mind that whatever technique you are familiar with, it's not only the familiarity which determines your choice of the bifurcation. Thank you.
This was really excellent and very, very analytic. I'm going to take a couple of comments. If you don't mind, go back to... Okay. So one thing to remember, if I may just give a... So when you have a dissection in the side branch, such as where you see here, okay, and you want to stent, and obviously this is the larger branch, the circumflex being all mostly in the groove, so this is the one you want to bank on. But irrespective, you already have a dissection and you already have a difficult angle. So when you want to stent, the first thing you don't want to do is take that wire out, not by mistake, but by strategy. For example, if you choose to do the culotte, I know this is obvious to most of you, but I want to say it anyway. If you want to choose the culotte, some may tell you take it in the, take the first stent down in the circumflex. That would be wrong. Why? Because then you would have to recross that stent into that marginal, which is already dissected and has an acute angle. So that would not be the right thing to do. The right thing to do, if you're going to do the culotte, is to stent across the circumflex. So take a stent from the ostium of the circumflex down the OM. This way, you've saved your OM and you don't have to recross it with a dissection. Now, you chose to do the crush, the DK crush, hoping that the stent will take care of that dissection. That's an option. Dr. Ka, would you have chosen a different option? For example, how about...
I think Dr. Gazelle has pointed out a very important point here. Because the OM is large, it's very dominant, but you have dissected anyway. So you want to preserve it first. You want to put a stent in. But then at the same time, you want to do a crush. I think that's where the problem comes in. If you put a stent in the OM and then go with the culotte procedure, then I think probably this will not happen. Because then you switch your wire, you just dilate the strut of the opening to the circumflex instead of crushing the proximal part of the stent. I think that's why the disaster happened. Because when you crush a stent in a very acute angle, the stent is not going to be squeezed like a toothpaste tube. It's going to be like crumbling a piece of metal back into the structure itself. So there's a lot of crumbling metal in the area, not in the direction that you want. And that is why crossing with the wire, crossing with the device is becoming so difficult.
And I think that's, Dr. Amin, what you tried to show here is how it's going to be crushed. Of course, this is all from, it's not proven bench testing, but I think it's pretty close. So perhaps I would agree, and that's, I think, the message of your case today. When you have such an angle, and when you have a dissection, and when you have a marginal which is so much bigger than the circ, and more important because the circ is going in the groove, there's only one little tiny PLOM that goes out of the groove. So secure that OM. Okay, so I would put a stent from the ostium of the circ to the OM, get rid of that dissection, and then if I can, and then it would be easy to go down with the wire down the circ, and at that point you have the choice of T or culotte or tap, while keeping your wire in the, well, if it's culotte, you have to reroute your wire, but if you want to do tap, you keep your wire in that OM. So there's always that advantage when we have a large branch is what technique can allow me to keep the wire in that branch without having to recross it again. That's, I think, part of my strategy when I think about it. But I think this is a very nice demonstration.
Again, it would be nice if you have IVUS or any intravascular imaging for us. It would be very, very informative.
That would have been, sure, of course it would have been an advantage, but remember we would have been able to cross with a small balloon, so definitely wouldn't have been able to cross with an IVUS catheter.
Even an IVUS pull from the OM back to the circumflex.
Yeah,
with the side look
maybe,
into the,
yeah.
It would be helpful. But anyway, it's a good case. Thank you.
Yes, please.
What size of stents are you going to use if you are going to use a culotte from side branch into the main branch?
Go back
And
to the image. So what size stent would you use if you were going to use a culotte? Yeah. Normally you size to the distal vessel. Okay. Normally you size to the distal vessel, and you can always pot in the proximal vessel. Dr. Amin, Dr. Kao, any?
Yeah, if you do have the main vessel and the side branch almost equal, so you definitely don't have any problem. So if you look at this case, you have a 3-0 in the OM and a 3-0 in the LCX. So probably a culotte will definitely be a favorable technique. Even if they are different, if you have the margin of expansion, for example, if this is a 3 and 3.5, you still can do a culotte technique. And one major advantage of the culotte is that you can do it whatever the angle is. This is not a problem like here.
And just please remember, anytime you put a stent across a vessel and you want to recross the branch, the side branch. So if you consider that now this is the side branch, you put your stent here. To recross, it's always better and easier if you do pot at the proximal edge. If you do the proximal optimization technique, and this has been the thinking in the last couple of years, number one, you've sized your segment here properly because usually you want to size this to the distal vessel and that one to the distal vessel. So here you size it to the proximal vessel, which is bigger. You keep the distal end of the balloon marker proximal to the carina. So you put your pot with the distal marker proximal to the carina, and it is said, and again, lots of thinking about it, but I'm not sure if I would buy this every time, that when you do that, you open up the struts here so that your wire can cross easier. Okay? So that's the rationale of a pot. Two things. One is to optimize the proximal, and two, to facilitate the entry into the side branch. Any other questions?
I want to ask something about the culotte technique. You put stent to the side branch and then made pot and then pass to the main vessel. Do you just dilate the stent with one balloon and then pass the stent, or made kissing balloon and then pass the stent?
You mean to facilitate the crossing of the main vessel stent? You may dilate the side cell. It's not a problem. You may just dilate it first and then then perform a final kissing. It's not mandatory to go for a kiss before you you do, this is not a decay, this is kilot. Just to facilitate, you dilate the side cell, nothing more.
Yeah, well, usually when I do culotte, I just dilate the side branch osteum. It's not like the DK, not like the crush, where it's mandatory maybe. But I think culotte is probably not that.
Let me ask about the decay crash. Except for the angle, there's some setting where you prefer to use some other techniques, like we've seen in the first case, a decay crash in a thrombus border, in a massive thrombus border, in a STEMI setting. And decay crash means more steps, more manipulation of the lesion, more whatever. Would you consider another technique in a STEMI setting, or it doesn't really matter?
Well, it depends. If you are pretty familiar with the technique, I think you can do the DK crush without much effort. Our next case will be in non-STEMI high-risk patients, and it doesn't take a lot of time to perform. This is not an emergency, like, for example, when you have the LCX and LAG occluded, and you might think of SKS, for example. This is a plain setting where the patient is stable. You can perform the DK crush without any problem.
Always do what you're familiar with,
Yeah.
and especially in STEMI situations. But it is many more. It's 5 steps, so certainly more manipulation. The tap technique is the simplest, but again, it has to be done properly. The advantage of the DK crush, always you keep your wire. You remove your wire from the main vessel for the rest of the procedure. So that's one advantage. Crush or DK crush. Okay, well, thank you so much.
Thank you.
Very good.
Thank you.